Swinburne University of Technology.
Good evening, ladies and gentlemen, alumni, colleagues and friends of Swinburne. My name's Michael Grigoletto and I'm from Alumni and Development. It's my great pleasure to welcome you here this evening for our inaugural Barbara Dicker Oration. I'd like to begin by respectfully acknowledging the traditional owners, the people of the Kulin Nation, as the custodians of this land. And we also pay respects to all Aboriginal community elders, past and present, who have resided in the area and have been an integral part of the history of this region. It's a pleasure to see so many of you here for what is a very special evening this evening for the Barbara Dicker Oration. Before we get underway, there are just a couple of housekeeping rules. We won't call them rules, we'll call them advisories. Firstly, can you please turn your phones off or have them set to silent? Secondly, we'll be having a business card draw at the end of the evening, so we'll hopefully you've had a chance to drop your card in the bowl. If not, it's probably too late to do anything. But anyway, there we go. The lecture tonight will be recorded for podcasting purposes, and we'll have a couple of roving microphones. So put your hand up, say you want to ask a question, and then just hold fire and we'll actually get the microphone to you as quickly as we can. So we've got a couple of very athletic people running around with microphones, so hopefully that'll work for us. At least 1 in 5 people are currently experiencing a mental health problem. In our lifetimes, 1 in 2 of us will experience a mental health problem. Mental health disorders are now posing a greater burden than physical disorders, and this trend is set to continue. A couple of years ago, Swinburne initiated a conversation with Mr. Ian Dicker AM and the Dicker family to explore how we might develop an initiative that would help current and future generations suffering the effects of mental health disorders. In memory of their late wife and mother, Barbara, Ian and the Dicker family have very generously established the Barbara Dicker Brain Sciences Foundation. Through applied research and community activities, the Barbara Dicker Brain Sciences Foundation will aid people suffering from dementia, depression and sleep disorders. Tonight is an opportunity to thank Mr. Ian Dicker, the Dicker family and friends who have so generously founded this endeavour. A favoured definition of philanthropy is the love of humanity, love in the sense of caring for, nourishing, developing or enhancing, humanity in the sense of what it is to be human or human potential. It's now my great pleasure to introduce a man who is the very embodiment of this definition, ladies and gentlemen, Mr. Ian Dicker.
Vice-Chancellor, Minister, Professor McGorry, my family, friends and guests. I welcome you all and thank you for your participation today. It's a great pleasure for the Dicker family to be here for the inaugural Barbara Dicker Oration to be delivered by Professor McGorry, and we thank you in advance. My congratulations, or our congratulations, go to Swinburne University for the establishment of the Advanced Technologies Centre, which has been the core of the Human Brain Research Centre, which we have been involved in, and that Brain Research Centre is outstanding. Barbara I'll be right. Barbara was born in Hawthorn. She grew up in Barton Street, Hawthorn, had 2 grandparents lived in the same street, and that was her early days. She often walked through what is Swinburne today, through to her uncle's shop front down there. Keith Miller was the real estate agent right opposite the town hall. But more important, with her father or auntie, she walked to Glenferrie Oval. As a child, Barbara played in the cricket stand at Glenferrie Oval in the 1940s, I'm talking about, and watched her father, Harry Pill, play baseball on the Glenferrie Oval in the morning, and then stayed under sufferance to watch the consistently unsuccessful Hawks. They didn't get into the finals until 1957. Barbara has always cared for others first. Her children, her grandchildren, their friends, and she was a friend to a lot of young people. As a physiotherapist, her medical background always challenged what was going on. She would be very pleased with what we're doing with Swinburne. Swinburne's administrative staff and scientific staff are outstanding, and a major reason the family decided to commit to a 10-year program of research in hope that some of these research pieces would help many people. In the first year, 10 research projects were concluded, and there are 9 outstanding this year. We know, the Dicker family know, the enormity of the problems in the community, and know ours with Swinburne is just a drop in the ocean, but it may help. We are pleased that these grants have excited the Swinburne community, as in year 2 there was substantial competition for the grants. But back to Hawthorn. In 1996, we were on our knees, broke. We did not complete paying the players for the 1996 year until April 1997. What turned Hawthorn around was a lot of people, volunteers, believing they could help make a difference in their small way. And it did. Look at Hawthorn today. So like the Hawthorn volunteers, we think with Swinburne, a number of small research issues each year may help resolve some of the major issues. I thank you for your attendance and look forward to listening to Pat's oratory.
Thank you, Ian. It's now my privilege to introduce the Honourable Mary Wooldridge, State Minister for Mental Health, Women's Affairs and Community Services. Following her election to Parliament in 2006, Mary was immediately elevated to the Shadow Ministry and had responsibility over 4 years for a number of shadow portfolios, including community services, mental health and the environment and climate change. With the election of the Baillieu Coalition Government in November 2010, Mary was appointed the Minister for Mental Health, Women's Affairs and Community Services. Prior to being elected to Parliament, Mary was CEO of the Foundation for Young Australians. She won a national award for this leadership and was also a finalist in the Telstra Businesswomen Awards. Previously, Mary was Senior Advisor to the Federal Minister for Industry, worked in New York with McKinsey & Company and with Consolidated Press Holdings in Sydney. Mary has a Master of Business Administration from Harvard University and a Bachelor of Commerce with honours from the University of Melbourne. Ladies and gentlemen, please join me in welcoming Minister Mary Wooldridge.
Thanks very much, Michael. I must say I thought I've got to make sure I make it over that little lip on the front, and of course the first thing I did was trip over. It's a real pleasure to be here tonight with all of you, and congratulations everyone on coming out tonight for this important oration from Pat McGorry around mental health, and it's a pleasure to see the room so full. I do want to recognise Professor Linda Christensen, the Vice-Chancellor, and of course Professor Pat McGorry, who we all know, such a distinguished Australian. I particularly do want to recognise Ian Dicker and his family, all of whom, or many of whom are here tonight, because we wouldn't be here without Ian and his passion and commitment to supporting research into dementia and mental illness, and also how research can make a real and practical difference in the lives of people experiencing those challenges. It's a real credit to you and the family, and of course Barbara and her memory, that you have invested in the foundation and invested in this oration, the inaugural evening tonight, so that we can all engage on these issues, which is such important for all of us across the community. I also would like to acknowledge the traditional owners of the land who have loved and nurtured the land we meet on tonight for many, many hundreds of generations. And my role is a short one tonight, and I'm very pleased to be able to participate and open the inaugural Barbara Dicker Oration. And it's the Barbara Dicker Brain Sciences Foundation, and I think you all have a brochure on your chair, is such a wonderful example of the partnership that can be established and has the potential to enrich our knowledge and expand our capacity to really improve the quality of life for people with a mental illness. And as I've said, it's Ian's commitment to supporting mental health research will not only benefit people with dementia and mental illness, but I think also inform the broader Swinburne research agenda, and that's very valuable as part of that partnership and the impact that it has. Now, we know that mental illness has such a devastating impact on a person's life, but also more broadly and particularly to families and carers. And that's why it's so important that we continue to improve the early detection, the treatment and support services that Victorians with a mental illness are able to access, and of course for all Australians. But we can only achieve these improvements in treatment and care if it is underpinned by a very strong and robust evidence base. And that's fundamentally what we're talking about here tonight. And Swinburne has very much to be proud of in terms of the health and medical research, both in terms of the facilities which we're seeing tonight, but particularly in terms of the experts here, real leaders in the fields of research in this area, who are pushing the boundaries on innovative solutions and contributing both to national debates and international debates about the practice and policies for people with a mental illness. And these are supporting significant improvements over time that we're all seeking for people with a mental illness. So I really want to congratulate the university for this leadership and for the commitment to what I believe, and I think many here tonight believe, this very important area of endeavour. And one thing that I'm very pleased in context is that we're very proud of our mental health system here in Victoria. We believe we have a very good mental health system internationally, but and also from across Australia. But we know that there are significant opportunities to continue to improve, to continue to push the boundaries about what's possible. And we're trying to work through that process of improving the way we provide care in the community for people with mental health, pushing the boundaries on innovative, different models, rather than providing all the care in inpatient facilities. And that includes some of the world-leading research and delivery of services that Pat McGorry leads through Origin. And we're, I think, very proud and pleased as a government that we continue to support and expand those models that he's developed here in Victoria across more broadly for Victorians, but really on the national stage as well. And in tonight's context, I think it's really important that we make sure that our state-of-the-art mental health services are working closely with the research institutions so that we can continue to push that boundary, have that evidence base and push that boundary about new ways to more effectively support people with a mental illness. Now, we're currently in the process of assessing proposals for a commitment we made of about a $10 million mental illness research fund to support mental health research in Victoria. And one of the things that I'm very pleased about is the parallels between the work that's happening through the foundation and clearly such a clear commitment from Ian Dicker and the family in terms of their support about how we must have the research, but it must have that collaboration and partnerships with the whole range of service providers to make it happen, but it also must have that practical impact, that it's not research for research's sake, but the translation of that research to actually achieving outcomes of better health, better well-being for people with a mental illness. And there's a lot of parallels in terms of the work that's happening here and where we're investing for further research for all Victorians. So I do want to congratulate Swinburne for some of the really interesting work that's happening here, and as I say, that translation of the research to a very practical impact and outcome. The other thing I think Swinburne's doing very well is the use of new technologies being brought together to offer new insights and new ways and to tackle the problems that in the past have often seemed very difficult to crack and address. And some of the work, and I think the collaboration, is bringing together groups such as biomedical engineering, healthcare services and research to understand better the structure, the function and the operation of the brain is some of the things we're seeing right here in this building. And the world-class anxiety online website and the e-therapy groups are just another example of that practical application and the positive outcomes for people with a mental illness. So I want to congratulate everyone who's involved in the Barbara Dicker Brain Sciences Foundation for the work that you're doing really in terms of pushing those boundaries and achieving better outcomes for people with a mental illness, and say how pleased and proud I am to be here this evening. Now it is on, I think, probably to the main event, and I do want to say just a few words about Pat McGorry, who, as I mentioned at the beginning, is such a distinguished Australian. He is an incredible advocate, and I've got to say I'm on the receiving end of a lot of that advocacy. He is a fantastic advocate for mental illness. He is always interesting, often provocative, and I'm sure will inspire us all with his vision for the future of mental health services in this state, this country, and more broadly. So it gives me great pleasure to formally open the Barbara Dicker Oration. I know you'll enjoy it. Thanks very much.
Thank you, Minister. It's now my great pleasure to introduce our Vice-Chancellor in Professor Linda Christensen. Originally hailing from Canada, and that's a point that we have to clarify because we all thought the accent was from Perth, Professor Christensen's academic career spans 30 years and includes participation in university education and research in 3 countries, Canada, the USA and Australia. The last 15 years of her career in particular have been focused on the impact of chronic diseases of ageing on individuals and families, highly relevant to tonight's conversation. She has served on the National Cancer Institute of Canada Research Scientific Committee and the National Health and Medical Research Council in Australia. In 2001, Professor Christensen took up the inaugural chair of palliative care at the Cancer Council of Western Australia. Between 2000 and 2006, Professor Christensen was active in developing centres of excellence across a range of disciplines, including medicine, engineering and computer science, working effectively with a number of universities nationally and developing relationships with industry. In 2002, Professor Christensen was named the Australian Telstra Businesswoman of the Year in recognition of her entrepreneurial work in health and science. Just a few months ago, Professor Christensen was awarded the Bethlehem Griffiths Research Foundation Medal. This annual award is made to a medical researcher or clinician working within Australia who has made an outstanding contribution in the area of progressive neurological disorders or palliative care, either in basic or clinical research activities. We're delighted to announce that Linda has chosen to direct the grant she received with this award to the Barbara Dicker Brain Sciences Foundation. Ladies and gentlemen, please join me in welcoming Professor Linda Christensen.
That was graceful, wasn't it? We're going to have to do something about that step. Thank you very much, Michael. Let me begin by offering a warm welcome to the Honourable Mary Wooldridge. Thank you so much for your kind words. A special welcome to Ian Dicker and his generous family who've helped us do the right thing here tonight. Professor Patrick McGorry, it's an honour to have you give the inaugural address, so we're very much looking forward to your words. To alumni, colleagues, past colleagues and staff and friends of Swinburne, thank you so much for being here with us on this special night. This is a special night for the Dicker family. It's very important to Swinburne. It's important to mental health research. And by the response to the invitation, it's clearly an important topic for all of us. It's a great privilege to welcome the Dicker family and to be able to introduce our guest speaker, Professor McGorry, for this inaugural oration. Professor McGorry is a leading international researcher, clinician, mental health advocate and leader, and we know his work particularly through his work for young people in the community. He's the Executive Director of Origin Youth Health Research Centre and Director of Clinical Services at Origin Youth Health. His work is to improve the youth mental health sector and in the process transform the lives of tens of thousands of young people around the world. It is indeed a great privilege to have Professor McGorry deliver the inaugural Barbara Dicker Oration. The Barbara Dicker Brain Science Foundation has been established by the Dicker family, as you've heard, in memory of Barbara. It's through the generous support of the Dicker family that Swinburne has been able to establish Australia's first multidisciplinary mental health institute. Many of us here tonight have been touched in some way by depression, dementia, sleep disorders, or anxiety, whether it has been through personal experience or through a family member, friend, neighbour, or work colleague. The collaboration between Swinburne and the Dicker family enables further research into these critical health issues. The Barbara Dicker Brain Sciences Foundation supports applied research in brain and psychological sciences with a view to helping diagnose, treat, and prevent sleep disorders, anxiety and depression, and dementia. The ultimate goal is to find a cure, treatment, or prevent these conditions. Mental health research is an important priority worthy of support, and we believe that we are making a significant contribution to the community in mental health. Swinburne has invested $40 million to establish Australia's newest and most complete human brain imaging research centre in this Advanced Technology Centre, the very building you're in tonight. Incorporating state-of-the-art equipment, including a magnetic resonance imaging machine and Victoria's first MEG machine, Swinburne can now offer researchers the full spectrum of multi-modality imaging. This infrastructure and equipment is complemented with clinical interview rooms, computing facilities for image analysis, clinical trials capability and e-therapy facilities, cellular neurosciences and genetic laboratories, and even a baby laboratory. That's to look at the early mental health issues of small children, and it's an amazing and inspiring place. Our research covers cellular and genetic science all the way through to brain and behavioral sciences. We focus on the translation of research findings and psychological knowledge into practical applications to improve the well-being of individuals, groups, and communities. A wonderful example of this is our e-therapy group, which leads the world in the development and dissemination of online treatments for mental health disorders, such as anxiety. Swinburne also has significant expertise in treatment of schizophrenia and hoarding disorders. We are proud of our world-class brain and psychological sciences research centre here at Swinburne and are immensely honoured to have the Barbara Dicker Brain Sciences Foundation underpin our broader research efforts. The Barbara Dicker Oration tonight honours the memory of Barbara Dicker and the philanthropy of the Dicker family, whose generosity will help many others to progress their mental health research. Most importantly, this work will help improve the lives of those touched every day by mental health disorders. I'm now delighted to hand over to Professor McGorry, who I warmly welcome to Swinburne for the inaugural Barbara Dicker Oration. Thank you.
Thank you. Thank you.
Well, good evening, everyone. Thank you very much, Vice-Chancellor, for that very warm welcome. Thank you, Minister, for your kind words. Thank you especially Mr. Ian Dicker and his family for the huge honour in being invited to give this inaugural lecture in memory of your wife, and I really hope I can do justice to it. So, and I'd like to thank Mike Kyrgios as well, who's my old friend from Melbourne Uni and who's doing such great work here at Swinburne, and we had a great discussion about this about a week ago, preparing for it. So, and thank you all for coming, as Michael said. This is a very important topic, and I think Linda just said most of us in the room have been touched in some way. Maybe I could just check how many of us have been touched. Can you put up your hands if you've been touched, either yourself or someone close to you, by mental ill health at some stage in life? Yeah, thank you. That's underlines the importance of what we're talking about tonight. Okay. So this is something that we had the great privilege of presenting to COAG last year on behalf of mental health. David Capo, myself, and Frank Quinlan from the Mental Health Council. And so the premiers were all sitting around the table with the Prime Minister, and we talked to them for an hour about mental health. And this is the message that we tried to give them, that people with mental ill health need a fair go in Australia, and they currently don't have it. And you know, the basic principle is that they should be able to expect the same access and quality of care if they're experiencing mental ill health as if they're experiencing physical ill health. And currently that is not the case in any part of Australia, as probably many of you in the audience are all too well aware. I think I was talking to Leon Kempler beforehand, and we were discussing what the real level of mental ill health in the community actually is. And I guess this is relevant to Ian's introductory remarks too, but I'm not sure who's playing that day. It's a bit hard to tell, but the point of the slide is that if we fill the MCG up 40 times, that would be the number of people in any given year in Australia who are affected by mental ill health. It's sort of the 1 in 5 figure, but you need a visual, I think, to see how many people that actually would be. And this is not the worried well. This is not people who are just getting over a tough time. This is people who are diagnosable with mental disorders. You know, sure, moderate to severe, but it's not a trivial thing, and it's the biggest cause. I think the Minister mentioned the NDIS, or maybe she didn't. Maybe I was imagining that, but the disability, the issue of disability, the biggest cause of disability in Australia, non-fatal disease burden, is actually mental ill health. And it's across the whole spectrum. So that gives you some idea. If you fill it up about 11 times, that's the number of young people that are affected by mental ill health every year. What have I done? Turned it off. Can we turn it back on? Is that possible? Good, thank you. It's a short lecture. So this is the disease burden at the top. Are you familiar with the burden of disease idea? It's a way of measuring. The World Health Organization worked out a way of measuring the impact of various kinds of illnesses. And obviously death is a pretty severe impact of illness, but this also measures disability. And if you look at that, you can see that across the lifespan, mental health is probably number 3 in terms of total disease burden. It's about 14%, 13-14%. Cardiovascular disease about 17%, cancer about the same. But if you look at younger people, and if we look at people up to middle age, it's about a third. It's the biggest single thing in the prime of life that is going to cause disability. If you look at people under 25, it's 50 to 60% of their health problems. So it gives you like a snapshot of what we're dealing with here. And if you look at research funding, which I'll come back to at the end, because I'm going to focus towards the end of the talk about mental health research, which the Minister's already touched on, you can see that we are not getting a fair deal in the research community in mental health at the moment. Look at the immunology, cardiovascular, cancer, they're way up. Mental health, way down. It's the lowest of the major priority areas. So it's not a level playing field. We don't have equity in clinical care or in research. But I could say how heartened I am to see you all here tonight, because a room full of people like this is showing the sea change that's occurring in Australia around this issue. This would not have happened 10, 20 years ago. Unfortunately, we're still pretty low down in the pecking order in terms of healthcare funding. We currently receive about 6 or 7% of the health budget, even though the burden of disease is about 13%. And even the investment in the federal budget last year didn't really do much more than just keep pace. In fact, we dropped back a bit because there were increases in health expenditure, health investment in other areas of healthcare, which brought the rest up. So even that investment did not actually improve the situation. So we still have a major battle on our hands to get the sort of investment we need. And I did have another category above mental health before. I think the NDIS might have moved up last week. So obviously there's overlap, but you can see how political this is. We will not actually get anywhere unless we actually get the support of the public, which empowers the politicians and the ministers to actually, fight in cabinet for resources for this area. And that's been the traditional Australian approach until recently, until about the last 10, 20 years. And I think that didn't work particularly well. And I think this was in the 2010 slide. There was tremendous outcry over the budget in 2010 when mental health was once again ignored in the national reform process, even though it was a key part of the Bennett inquiry, the Health and Hospital Reform Commission, and that obviously got reversed fairly quickly. Now, why is this important? I'll just tell you a little story here. There was a consumer in one of the Mental Health Council's consultation groups who told a story about her experience. She was a middle-aged woman who'd experienced breast cancer. She detected a breast lump, and she went to see a GP. I think it was the next day that she was responded to. She was brought in. There was a biopsy taken. She had a simple operation, and luckily the cancer had not spread. And she woke up after the operation in a room full of flowers and chocolates with all her family and friends around her, and just a totally, if you can have a positive experience in that setting, the experience from a healthcare point of view was very, very positive and supportive and very fast. She also suffers from mental illness, and she had a relapse of the mental illness, a severe episode of depression about a year later, treated in the same healthcare system, had desperate trouble getting actually into the system through the rotating blades of the triage system, which was very, very difficult to get into care. She finally did get in and got treated and recovered, but when she was in hospital for that particular problem, she didn't wake up in a room full of flowers and chocolates, nor did she have lots of friends and family sort of coming to visit her and around her. So the experience, it was a sparse, difficult experience of healthcare in the same healthcare network. Despite mainstreaming of mental health into physical health 10 to 15 years ago, the experience was completely different in terms of access and quality. So same woman, same healthcare system. So when I use a slide like this to talk about apartheid in healthcare, I'm not talking about one group of people who are missing out and another group who are getting access. It's the same people. It's any one of us would have that experience if we try to pursue it. And that could actually be in the private as well. The quality in private psychiatric care is also a lower quality of care than compared to other areas of medicine and healthcare. We've got a lot of work to do. Okay. The public, on the other hand, are ahead of the game. This is an international survey that was done in 2010 by the King's Fund, and it showed that Australians, and I think it's good that the CEO of Beyond Blue, Kate Carnell, is here, because Beyond Blue, I think, have been very strongly responsible for this, and pay tribute to Jeff Kennett here too, because attitudes in Australia and knowledge about this issue have really improved in the last 10 to 15 years. And that means that 35% of Australians rated mental health as one of the top 3 issues, along with climate change and the economy. And that's a pretty big statement, a pretty big turnaround, I think. In countries like the US or the UK, it was only about 10%. So we're actually doing well as a society in terms of starting to change our attitudes and recognise the importance. This is from the National Mental Health Survey, and it shows really the patterns of mental illness across the lifespan. This is prevalence, 12-month prevalence rates. And you can see that the only good news about getting older is that mental health tends to get better. I'm not quite sure why that is, but obviously there's issues of dementia that affect a lot of people too, so I'm not trivialising that at all. But from a general point of view, the other psychiatric disorders tend to occur in younger people, and yet and you can see the pattern. The main things are, we've been talking about anxiety and depression tonight, and substance use disorders. That's another big thing, especially as you can see in younger people, and obviously the serious illnesses like schizophrenia and bipolar disorder are there too. This is a very encouraging trend, and I think this is going to help ministers and governments to address it, because this is the World Economic Forum, with 3 sets of economic analyses last year, September, looking at non-communicable diseases, and it showed that over the next 20 years, mental illness will be equal first with cardiovascular disease as the biggest threat to GDP. So, in other words, it's going to reduce the economic productivity of countries if we don't actually deal with this. And the human argument is very powerful, obviously, isn't it? And it moves all of us, but it hasn't been enough on its own to actually change policy and investment, I don't think. So the economic arguments are becoming increasingly important. And Ernst & Young, in partnership with the Inspire Foundation, put out this report recently looking at young men, and they showed that, I think the figure was $3.27 billion a year lost to the Australian economy as a result of mental ill health in young men. And that's a big number, I think. And the thing is that it's so reversible, it's so it's such a soft target in one way if we did something about it. Those are the headlines. I won't go into the details, but so mental health reform, what I'm trying to say is that it's something which has languished, really. It's a very difficult thing to do. I can speak from, as the Minister alluded to, from personal experience. It's a challenging thing, and it's not because politicians are resistant. It's because there's so much inertia in the system, and it's hard to get things to change, and it's hard to get investment in new things. But I think it's still the most achievable and the most cost-effective reform. We saw with general health reform how difficult that is. The Health and Hospitals Reform Commission process showed general health reform is very challenging. It's very complicated. Mental health reform, most of the time people agree on the things that need to be done. And the public are in support of it. And I think it could be a lot more clear-cut. So I'm pretty optimistic, really, in the long term. It's popular, as I showed you. I've found that it only works if premiers and prime ministers get involved, because it's a whole of government thing. It goes, as the minister knows, it goes across portfolios, and it affects lots of things. It affects education, it affects correctional systems, it affects drug and alcohol. We had a chat recently about trying to integrate drug and alcohol services with mental health services. It's just completely dysfunctional that they're not totally integrated. Well, it goes wider than that even. There are many, many areas of government that need to be involved. So you need top-level support so that around the cabinet table, the poor old health minister or mental health minister doesn't have to fight for it on their own. What else? The other thing that is that there's often investment, but it's investment in things that haven't been properly road tested or evidence-based, to use the minister's term, and money is wasted as well. So we've got to invest, and this is why research is so important, why what we're doing here tonight is really vital. We've got to put the money into things that are going to work, not just things that people need. If we haven't got a solution, we can't throw the money away, and I've seen that happen too, as well. Money just, because there's a knee-jerk political reaction, money is wasted. So we've got to be sensible about this and have programs that are shovel-ready. And they take about 15 to 20 years to actually develop, test, and then scale up. That's our experience. The rest need R&D, and that's I think it's great to hear Ian and Mike and the Swinburne people talking about the practical side of research. That's been, I think, the hallmark of what I've tried to do in my career. I haven't spent my life in a lab, not to say that that's not really important, but trying to get things into the real world. There are advances that are ready to go now that we just don't make available to people because of the failure to translate. And I think the Swinburne approach is actually right on track. I think we've got to shift the focus. The Minister, I think she's given my talk already, but she referred to this. We've got to put the focus on the community-based efforts. There's no point in having all the ambulances at the bottom of the cliff. I'll come back to that at the end in terms of what sort of reforms we actually need. And I think if we do invest in it, there's this idea of the mental wealth of nations, and it's got to do with the social capital that we waste if we don't actually address treatable mental ill health, particularly in younger people, but across the whole lifespan. So I think there's a positive way forward for us, especially in Australia. Australia is the best country in the world, and Victoria, if it actually keeps or if it reinvents reform and investment in mental health, it can be the leader in this. It is the best place in the world to be doing this sort of stuff, in my opinion, as long as we can actually get the community to regenerate the momentum again. And I often say that I trained in the 19th century, and sadly people are believing it these days, but what I mean is that I trained in 19th century institutions and with 19th century ideas. And when I started psychiatry in the early 1980s, patients were told if they had a diagnosis of schizophrenia, you will not get better, you can forget about working, you're not going to recover, all that sort of incredibly demoralising, negative, pessimistic stuff. That was the belief system around that particular diagnosis, and the whole environment was fashioned in the 19th century, and it took us till the 1990s to sweep that away, or to begin to sweep that away. And we've sort of done a reasonable job of getting a next model, but we're only about halfway there. We didn't invest in it properly. We've underinvested in it quite seriously in terms of the level of need, but it is an advance, you know. But I'd like to see us make a big jump, not just a half jump and land flat in our faces, which to some extent we have done. Okay, so I think I've said some of these things already. We have got greater awareness and less stigma, and I think a lot of people have played a part in that, in Australia especially. We are ahead of the world in that respect. And, you know, we have mainstreamed our services into general hospitals, but that's caused a lot of problems as well, because a lot of people are now ending up in emergency departments who shouldn't be there. And you know, there's a much better way to actually be doing this. Hospitals, we're governed in mental health now through acute hospitals, and hospitals look at the world in a particular kind of way. They look at beds, and they look at the acute end of things, and they can't really get their heads around community mental health, in my experience. Financially, those services suffer in this model, and there's been a retreat, not so bad in Victoria as in other states, but in New South Wales it's probably been the most serious. The community-based mobile outreach sort of responses have really just withered on the vine. So with the result that government's been investing in emergency departments, putting more and more resources into the EDs, like bees to a honeypot, people come in, and it's really, you know, we've gone backwards in that way. So we need a really serious review of mainstreaming of mental health care and work out what we're going to do for the 21st century. And it's going to have to require a federal and state partnership to do this, because the investment that's going to be required to actually generate a proper integrated community mental health system is not going to be possible at state government alone, I don't think. So that's a big priority, to look at the reform that happened 15 years ago under the Kennett government. It wasn't looked at seriously over the last decade, and Victoria has gone backwards in some ways in that respect, I think, even though it still has the potential to lead the country, and in many ways the innovation is in this state. So I think we've got a great opportunity. I think I've mentioned those sort of things. So if you look nationally for a second at mental health care in Australia, this is a picture from 1929, I think, or maybe 1928. And, you know, you've got the state governments building the public mental health system, the system for the more seriously mentally ill. That's on the right there. And on the left, you've got the federal government building, you know, primary care, specialist psychiatry, better access, the sort of primary care-based type schemes and related sort of elements. And in the middle, and we saw this when better access was cut back a bit last year, you've got a whole lot of people who've got very limited access, or certainly limited tenure in terms of mental health care. A whole lot of people falling between these two cracks, not severe enough, not serious enough to actually be provided with mental health care in the public mental health system at state level, but they've run out of vouchers, if you want to put it that way, at the other end, and so they're falling between the cracks. Or the level of specialisation that they need is greater than what better access can provide with a GP and a psychologist, and yet the multidisciplinary team of the public mental health system is out of reach. So there's a big group in the middle, and I hear about this all the time. I see them in Headspace. I work in Headspace in 2 states, and I see these patients that have run out of time, or they're a little bit too complex for Headspace, but then we can't get them into the public mental health system. And what are we to do with them? What are we supposed to do? You know? And what are they supposed to do? And a lot of those people spoke out very strongly last year when better access was cut. The solution isn't just to restore better access, it's to add something much more strong in that middle arch. And so, you know, we worry whether the bridge will actually meet in the middle, or whether, you know, it'll just stay like that, or be dismantled a bit from one end. You know, I think some states are doing that. So, I mean, it's really a big question. What are we going to do to grow the system in the middle phase? Okay, so these are some of the other things we said to the premiers. There are probably 2 or 3 big things that we can do. One is to try to reduce the new flow of cases. So what can we do about prevention? How can we stop more people becoming mentally unhealthy in the first place? And the Minister mentioned early detection. Can we reduce the burden of disease by heading things off at the pass, reducing the impact of illnesses, disease-modifying type things, like we do with asthma and diabetes and cardiovascular disease, arthritis. And then a big thing, which was a legacy of deinstitutionalisation. Closing the institutions was good in so many ways, but the one thing the institutions did was give someone a bed for the night and a place to live. And a lot of the people that would have been these days in the old institutions now have very tenuous accommodation, or they're living with elderly parents, or they're homeless, you know, or they're in jail, actually. The number of mentally ill people in jail has gone up dramatically since the closure of the institutions. So that's one thing, housing and social inclusion, employment. Many people with persistent mental illness can work if the supports are there. I think this is part of the government's thinking as well, to provide vocational support for getting people back into education and employment. And this is possible. There's new research over the last 10, 20 years to show that it's very possible to do that if there's enough input to people. And obviously consumer focus. And the thing I'll finish on tonight is the public's role in this. What can you all do about this? You know, because I don't think any change occurs without very significant public support. We saw that last week with the NDIS. You know, the public have got power in these situations. That's what helps politicians to do what they want to do. You know, the politicians are in good faith, mostly, I've found, but they can't act unless it's clear that the community is behind the idea. And I think it's a very important lesson that I learned. So, prevention and early intervention. Delay, you know, it is a solvable problem. When I started work, patients with schizophrenia took a year or 2 after onset of illness to get access to care. Now it's down to a month in the western suburbs of Melbourne. So you can shorten those delays with the right sort of approach and model. That's what we try to do in cancer too, isn't it? And heart disease. If someone develops chest pain, you don't say, "I'll just wait until it wears off and, you know, go and see the doctor tomorrow." You say, "Go to the emergency department right now." If you've got a breast lump or if you've got a skin lesion, you're encouraged to seek help early. Well, in mental health, the system works against that because it's rationed and it's very hard to get the access, and so people are told essentially to come back when you really are more severely unwell. And so that's something that had to be corrected, and we're working on that. And we do have new models, as the Minister said, Headspace, Origin, Epic. These sorts of models, they need to be developed at other stages of life as well, for younger children and older people as well. And these are some of the things that, obviously across the whole life course, that the youth focus, for school-based and family interventions. One of the great evidence-based things in younger children is supporting parents. Parent interventions are a very evidence-based thing to be doing. There are other things as well, of course. And I think the middle adult and older Australians as well, because most of the investment in mental health care is in those age groups actually at the moment, but it's still well short of what's needed. And new models are needed, as I mentioned. Some of the models that are very evidence-based have been defunded. You know, in New South Wales, the home-based treatment services, the crisis teams, very evidence-based, they've all disappeared. So evidence-based care has got to be one of the key criteria, I think, for funding services. Home-based care, is a very effective sort of approach and keeps people out of hospital. So I'm going to talk for a bit now about the youth focus, if you forgive me, because that's probably what I know more about than anything else, so if you can just indulge me for a little while. But I think it's an example of combining a practical problem with research and how research can transform what we're actually doing. And the reason it's important, and just going back to the burden of disease issue, this is the burden of disease across the whole lifespan, and it's when cases of illness appear for the first time. And this is the only slide anyone ever remembers from any of my talks, so I'll leave it up for a little while. You can see, after 50, it's not very good news, I'm afraid. The burden of disease just takes a bit of an upswing, as you can see, and cancers, cardiovascular disease, strokes, respiratory, all of those things really become much more common, and there's a lot more disease in that age group of various kinds. In little kids, actually, as well, this is why I've just built a $1 billion children's hospital. There's a cluster of quite nasty physical diseases, and so that justifies us having a strong focus on primary school kids, little kids and primary school kids. But then from puberty through, not just to the mid-20s probably, but even up into middle age, we're pretty physically healthy these days. We don't have tuberculosis anymore. The old diseases that affected young adults and people in this stage of life basically aren't a big problem for us these days. Obviously there is some, but 60% of the illness in this age group is mental ill health and substance use. And so you can see that the logic of actually mainstreaming our mental health system or blending it in with the physical health system without any special engineering is not going to work. If we just assume it's a pediatric adult problem, and we just have services for little kids and for older people, which is what we've tried to do, that doesn't work. And with the result that the access to care for young people in this age group is very, very poor because the system isn't designed for them. And we've got this boundary at 18, which Victoria has in bipartisan mode, I think, abandoned, and has shifted up to 25 now. We're working towards a 25 boundary, which, as you can see, makes a lot more sense if there has to be a boundary at all. But the boundary at 18, it's okay for most physical illnesses, although I think Susan Sawyer from Centre for Adolescent Health would disagree with that, even so, with asthma and diabetes and so on. But especially for mental and substance use disorders, it doesn't make any sense at all. And the other reason it doesn't make any sense, if any of you that have got kids in this age group in the room, adolescence has extended a bit, hasn't it? Have you got kids still living at home at 24, 25? I certainly have. And the developmental change is really quite different these days. It takes a longer time to grow up and to become independent as an adult. At the same time, adolescence is starting earlier. So the developmental process of transition is different from what it was 30, 40 years ago. So those are the sort of arguments that we've been making. And this is a study from New Zealand which shows that it followed just normal kids from the end of primary school right through to the age of 30. And it assessed them very frequently with careful diagnostic interviews over that period of time. And it found that 50% of these young people were diagnosable with a period of mental ill health during this period. Now, some of that was mild and not that persistent, but about 2/3 of it was moderate to severe or recurrent. And 50% actually was recurrent. And despite this, you could, sorry, I'll just go back. You could say that, some people might say, well, it's just the worried well, it's just troubled teens, they'll grow out of it. But when they measured the earning potential, the income of these people at 30, and the number of friends they had, and their vocational achievement, it was directly proportional to the amount of mental ill health they'd had during that period. So it had real-world impact. It wasn't just a theoretical idea or something to be dismissed. So that doesn't mean that it all has to be medicalised, but people need help of some kind to get through this period. And there's a gradation, a proportional level of help that people need. And this is the sort of help that they're getting in Australia, although they were getting a couple of years ago. 13% of young men with a diagnosable mental disorder were getting access to care, 13%, and 31% of young women. And even older adults, the rate wasn't that much better, I suppose you could say it's about 40%. But you can see the young people had the worst access, and I think it's because of the design problems with the system of care as much as anything else, because we don't have as many financial barriers in our system as in other countries, but we have these cultural barriers, and I suppose the naive issue that they haven't actually used the health system before is another aspect too. So, you know, we've got these messages about early detection, early intervention, but that's not always the experience that you get when you go looking for help. And I mentioned the triage systems. Well, you know, it's people in mental health can be excluded on a technicality. You're living on the wrong side of the street, or you're in the wrong age group, or your illness is not severe enough, as I mentioned before. And you can see why, because the system's under-resourced, so people have got to survive when they're working in those jobs. They've got to prioritise. You know, if I take this person, then I'll have to exclude that person. And it's, you know, I work in it on a day-to-day basis. I've tried to refer people into my own service from the outside, from Headspace. You know, it's a constant struggle, and it's basically because the system is not built to scale. You know, and you could say the whole health system is always got that problem to some extent, but mental health's got it in spades. You know, and that's the equity issue that I was talking about at the beginning. And I think we are all, including ministers and bureaucrats and people working in the system, are trying to address it, but at the present time, it's not addressed. It's not fixed. And even if you get in, you know, I used to use this about the old mental hospitals, that if you happen to get into the service, you might wish you hadn't actually got in, and that's sometimes still the case. So the culture of care is really important. And this is why we've argued for special cultures of care for younger children, different cultures for the youth, and then different cultures for the middle-aged people and different cultures for the older people. It just makes sense. You feel more comfortable in those sorts of in cultures. And you've got to be able to trust the system, you've got to be able to trust the people and trust the relationships, especially in mental health. And this is a Norwegian slide sort of highlighting the same issue. I won't labour it too much, but when you're working with young people, you see them coming in for the first time with their first episode of care, and you know, if there has been a long delay before they've got help, these are the sort of things that happen. They're much more difficult to treat, they recover more slowly and less completely. They have a whole lot of complications like drug and alcohol problems, they have vocational failure, they have suicide attempts, and so on. Family stress. The families are at their wits' end quite often by the time they get access. So all of that psychosocial impact can be minimised or even avoided completely with a very, very rapid access sort of system, which is what we've been trying to develop. So the whole idea, you know, you wouldn't have to do this if you're working in cancer or in diabetes. You wouldn't have to start a new scientific journal to promote the study of early intervention or prevention in psychiatry. But because it was so not part of the furniture in clinical practice or in research, we had to do that. And actually, this is an attempt to try to stimulate researchers to embrace this paradigm. It's been a hard thing to do. It's been very strong in psychosis and schizophrenia, and we've been trying to shift it for the last 10 years into mood disorders, anxiety, Mike's work, depression, and other diagnostic areas, substance abuse, because the principle applies everywhere. It'd be hard to sort of from face validity point of view to actually say it wasn't a good idea. On the other hand, we do have to test it to see, you know, how to do it, and because there are pitfalls in it. You can, you know, you've probably seen this in the media. There's a risk of over-treating people. So if you see someone in the early stage of something, your responsibility is not to over-treat as well. You know, see it in cancer. And I think it was an article in The Age today about prostate cancer, about over-treatment of prostate cancer. Obviously, it's a good thing to pick up cancer early, but if you go in with the kitchen sink, you know, it's an over-treat. There can be a lot of secondary damage, and that's true in psychiatry too. For example, if every young person that was struggling and having a difficult time and needed support and counselling was given medication, that wouldn't be a good thing. And people have pointed out that controversy in the media, and so it's a fair thing to be worried about. So we've got to do this carefully. This is an example of one of the studies that we've done in this early intervention area. It's a study looking at people with sub-threshold psychotic symptoms who have been shown to have about a 20 to 40% chance of having a psychotic illness within 12 months once they have this clinical picture. And in this study, they were randomised to receiving fish oil, omega-3 fatty acids, or placebo. And the fish oil, along with general supportive psychosocial care, reduced the transition rate from about 26% down to about 2%. So at that stage of illness, with that level of less severity, something as simple as fish oil, in whatever way it's working, whether it's through anti-inflammatory effect or oxidative stress or membrane stabilization, whatever it is, it's doing something which it can't do later on. It doesn't work later on in the illness. So it's as if you present for your breast cancer with a small lump, a simple operation cures it. You present 6 months later when it's spread into the bones or into the lymph nodes, and nothing will cure it. Or cure will be much more difficult and cause a lot more sort of distress. So it's the same principle we're trying to test in psychiatry that in other parts of healthcare. And this is only one study, and it may not be replicated, so I don't want to oversell it either, but it's an example of what we're trying to do. There have been about 6, actually 10 studies of this nature done with different types of treatment, and it does look like we can delay the onset of psychosis with CBT, with a range of different options. And so it needs more research, but it's an encouraging finding, and it's an optimistic thing for the future. But we're not going to be able to do that unless we can provide access to people at a very early stage of the problem. And when they do get access at this stage, it's not as though they're actually functioning too well. Their GAF scores, this is the measure that we use for functioning, are in the 50s, which is about half normal. So they're really impaired in their functioning, even though they're still at an early stage of illness. So it's a justifiable thing to be offering treatment at this point, but the treatment hopefully will be safer and more effective. Okay, the other thing we have to do, coming back to the vocational idea, is a practical thing. As we get people better, and I think we can get most young people better from a first episode of psychosis, maybe 80%, but in the meantime, the peer group has moved on. They might have dropped out of school, they might have been struggling in lots of different ways, but if we can actually add to the normal treatment, something like a vocational recovery program, which actually keeps them in school or keeps them in work, they don't drop out. It's much more successful. We can get recovery rates of about 85% if we add in this simple additional intervention, which is basically not a clinician. It's someone from the employment or education sector sitting in the clinical service, working with the young people, working with the schools, working with the workplaces, working with the employers, and making sure they actually can get back on track. Even if they're not completely well, they can still return to a normal life. And the economics of this, as you can imagine, if you can actually reduce the impact of these illnesses, even if you're not curing them, you can modify the course. It saves a lot of money. It costs a third as much to treat people in these new models of care as it did in the old models. And this is why, I think overall it's a win-win situation. Sometimes critics of early intervention in psychiatry say, you're taking resources away from people with more serious illnesses and you're putting them into people in the early stages with less severe illnesses. But actually this approach will save money, which can then be available for people with more severe and chronic illnesses. And also it'll prevent people from getting into that position in the first place. So it's a very sort of logical sort of thing for governments to be doing, and they are supporting it. As the Minister said, all around Australia, in a policy sense, people might be arguing about the implementation details, but in a policy sense, like the NDIS, I think there's pretty bipartisan, unanimous state and federal agreement about this. This is the way to go. Some of the problems are within the professions and the systems themselves. There's inertia and resistance to change within the systems themselves. And I think that's as much of the problem as actually having to advocate with politicians. It's having to advocate with our colleagues sometimes to actually change. Okay, it's not just about psychosis, borderline personality, another very big and serious illness, which many clinicians have been very terrified by over the years. But actually, it's a serious problem. It has to be taken seriously, and now there are really good data coming out showing that it can be successfully treated as long as you've got an expert team that can actually respond with skill and engage the people. Depression as well. There's really good evidence for early intervention in depression. This is a group-based CBT program which reduced the risk of serious depression in young people. Okay, so this is getting international support, and I think this is relevant to Swinburne as well and the research happening here. This is Tom Insel, who visited Australia last year. He's the director of the National Institutes of Mental Health in Washington, and So the peak research funder and policy sort of body in research in the US came to Australia and he said, you are 10 years ahead of us in Australia in these ways. He's been writing for the last few years about preemptive psychiatry, which is the same sort of thing that I've just been talking about really, which is not necessarily saying we can cure these illnesses, but we can preempt a lot of the damage that they cause if we have a strong, proactive system of care. And that's what he's talking about here. And he's also drawing analogies with physical illnesses, cardiology, diabetes, and other sort of parallels. And this is some of his work writing about this, using the staging idea, that this illness occurs in stages. I use the cancer analogies quite a lot. But schizophrenia, let's say, can be in a series of stages, and the treatment is different according to the stage of illness. And that's what he's writing about here. So this is a model which could go right across the whole spectrum. You know, we pick up the illnesses in the early stages before it's even clear what the classical picture is actually going to be. It's very easy to recognise someone with schizophrenia after they've had 10 years of illness, or someone with bipolar disorder after they've had 15 episodes. But when they're first becoming ill, it's kind of difficult unless you've got the right sort of diagnostic model. And we haven't got that yet. We've got to work on that. You've probably seen the controversies about DSM-5. We had, you know, the creator of DSM-4 out here recently doing a mea culpa, what terrible mistakes he had made with DSM-4. Well, it's right. You know, the classical diagnostic system is not working well for us, and particularly in terms of early intervention. We need a simpler model, and one which is, again, coming back to the practical task. What do you do to help people when they present for help? What is the evidence-based thing to do at that particular point in the illness? And DSM is not very helpful in that respect. And so it's also good for the other aspects of Swinburne research, tying in the biomarkers, tying in the imaging, tying in the diagnostic tests. If we can divide it up by stage as well as by syndrome, that might actually throw a lot more light on what we're actually finding with our research, and also validate some of these treatments and diagnoses as well. So back to the real world, and so if we're going to apply this sort of staged idea in the real world, we've got to get very close to the community. So we've got to have very good awareness and understanding of what the difference between just having a bad day and having a persistent problem with mental ill health. People have to know that. And it doesn't mean they have to be diagnostic experts, but they have to recognise when someone's struggling. And it's quite simple. People who are distressed in a persistent way and their functioning is being impaired, that is a mental health problem. You know? And you know, someone like that does need to have some kind of assessment, I would think, if it doesn't clear up with normal support from family and friends. And so that's the first stage. And then the people who are on the front line are the psychologists, the counsellors, the GPs, the school counsellors, you know, a whole range of people in the community who encounter this. It could be football coaches. I mean, I remember when my kids were playing junior footy, the football coaches would, probably a fifth of the team at any one time would be having some kind of issue. And so they have to be able to recognise when a kid is struggling and respond in a good way. And it's the same with AFL teams. We had a meeting yesterday with the AFL Players Association about this. I mean, it's an important duty of care issue. So how do we strengthen the system for young people? And I think we've made, of all the countries in the world, Australia is ahead in this reform. We actually are doing this, strengthening the system on the basis of what we've been talking about. The first thing is, obviously, we don't want to make the situation worse. First principle of medicine is don't do any harm. And I think a lot of the old psychiatric systems were doing a lot of harm to people, and that's why they had to be reformed. And I think, you know, it's true in any system. You've got to look at risks and benefits. And I don't think, unfortunately, just putting a few band-aids on the existing system is going to do the job. We have to have transformational reform. We have to create new systems of care for the 21st century, not patch up jobs from the late 20th century or, you know, we certainly don't want to go back to the 19th century. But we need not that, but we need a new building, actually, not a patched up building. So a new architecture and culture of care. And this was very strongly supported by the National Health and Hospitals Reform Commission. They went through all the evidence for about a year and a half in mental health. They came up with 14 different recommendations, and the top two were to do this proactive thing, this front-end focus on young people. Headspace is the first one, the community-based, youth-friendly system of care. and then a backup system, which is EPIC, which was developed in Victoria, launched by Marie Tien in 1993, and has been developed in many countries around the world now, and now coming back and being hopefully rolled out around Australia. But what we need is probably something more than that. We need a broader spectrum backup system for the Headspace model. And what are we talking about? Well, when I try to explain this to audiences, I try to use this analogy of the iPhone. I don't know if it always works, but if we're talking about something 21st century that we want our mental health system to be like, the iPhone is that in my mind, because it's something that it's an attractive, engaging thing that everyone wants to have. Everyone's engaged with it. It's a one-stop shop. It does things with one piece of equipment, whether it's an iPad or an iPhone, that used to have a briefcase full of different appliances and, pieces of equipment that you have to carry around. So it brings everything together in the one place. And that's what young people, that's what all patients actually need, but particularly young people who are not going to be able to navigate their way around a complex system of care. And this would be the Headspace picture, where a Headspace should have to have a GP, allied health staff, vocational staff, family support, youth participation, crisis capacity, e-health. Those are the sort of things you need in a youth-friendly youth health centre. Those are the things that will meet their needs. For younger children, it would be a different group of professionals. For old people, it'd be another group. You'd have to have physiotherapists in there somewhere and dietitians and stuff like that. But young people, these are the main things that they need. And then below the line, that's where the specialist mental health system comes in, the additional applications that you need to provide backup, inpatient care, mobile home treatment, group-based programs, specialised diagnostic streams of care. That's got to be built into the system as well. Our mental health system is very generic in Australia. Since it was deinstitutionalised, there's very little specialisation within it in terms of diagnostic streams or particular sets of problems, and that's something we've got to rebuild as well. So Headspace is going to be in 90 places around Australia by 2015. It's already in 40, and I think about 10 or 11 in Victoria. And Victoria the Victorian Headspaces are working well. It's relatively standard. If you go into a Headspace anywhere in Australia, I've been to most of them, there's a very similar culture, similar feel, very welcoming. So the reception staff look like they're happy to see you when you walk in. It's friendly, flexible. The professionals can actually talk to each other in a flexible way. You see someone, you go and talk to the psychologist, talk to the youth worker. It's a breath of fresh air, really, when you compare it to much more rigid models of care. There are no grills separating the staff from the patients. The waiting room is very open and flexible, and it's in the heart of the community. It's in shopping centres. I'll show you a picture or two of that. That's the one on the Gold Coast. So right in the heart, and people said they won't go because it'll be stigmatised. It's the opposite. It's almost stigma-free, even in country towns, especially in country towns. This is in Coffs Harbour. You see Indigenous kids there too. In Ireland too, this model's been rolled out as Headstrong, or Jigsaw is actually the actual service model. This is the new facility in Galway. This is the type of decor that they have. And this is the Irish Prime Minister, the Taoiseach of Ireland, launching the new facility in Galway. The Irish President has visited it too. That's what I mean about having top-level support in government. If you can get that, these sort of reforms will move much more slowly, much more quickly. And that's Julia Gillard last year after the budget at Western Headspace in Sunshine. So you can see engaging the leadership is important. The backup system is still not anywhere near built. So when the patients get more complex or need longer term care, we still have a lot of trouble knowing where they can go, and the places are very, very limited. So you could say we've built a base camp here, but there's another mountain to climb, really. And this has to happen across all age ranges, I think. We've got to rebuild and strengthen it across all age ranges. This was done as a national and international consultation last year to support how the EPIC model would roll out across Australia. There are 16 components to it, and we have to have fidelity to this model if it's going to actually change lives. If we just put the resources into standard adult mental health care or CAM services, we won't change anything. So it has to be high fidelity. This is an evidence-based model. It needs these components to work. And that's what we're negotiating with governments around Australia about now. These are some of the key elements that we need to see in all services, I think. And this allows me to come back to Mike's work and what's happening at Swinburne, and the Minister mentioned this. The e-health area. This is another 21st century thing which is allowing us to provide mental health care into remote parts of Australia, and to complement the care that's provided by face-to-face care in other parts. And one of our researchers, Mario Alvarez, has developed this whole suite of programs to complement what is provided within Origin, so in between appointments and after people are discharged as well. And I know Mike's done some great work in anxiety around these things too. So this is the way of the future. It's what young people will really go for, and they already are. E-Headspace is a program that's been, I think it's treated about 5,000 or 6,000 young people online already. So this is very exciting, and we can integrate that with new models of care as well. This is the CRC that was funded by the federal government a year or two ago to promote this, and Jane Burns is the CEO of this. So, talked a lot about young people. The other big group, and I think Alan Fells, who's the chair of the National Mental Health Commission, is very clear about this. We've got to actually provide a kind of a repair operation for the failures of mainstreaming here. And that's really about a decent and secure place to live for everyone with persistent and severe mental illness. The Haven project in Melbourne is something that Alan's led, and it's working well. There are other examples of similar models around Australia, but they're isolated examples. So many people with serious mental illness haven't got a secure and safe place to live. And you can't treat people without, you can't provide all the other, it's like a hierarchy of needs: food, shelter, safety, and then, therapy, or maybe a few other things in between even. But you have to have the right secure context, and so it's very, very important. I think already talked about the need to strengthen the community mental health focus. It's not to say inpatient care isn't vital, and the quality of it is really, really important to get right. But we've got to actually grow and expand the community side, and then our inpatient units will be able to function in a much better way with less pressure and become more therapeutic again, because they're not really therapeutic places anymore. They're more risk management environments, and the same with a lot of the work of CAP teams, unfortunately. It's all about risk and not about care. Obviously, we've got to manage risk, but we're managing too much of it because there's not enough care going on in the community. The NGO sector, I should mention, is a very important part. And I'd like to see a much stronger integration of governance between NGOs, primary care, and what we're currently providing through public mental health through state governments. So this is about the Commission, which I'm sure you know about. The Commission has been set up to try to monitor progress, and several states have set them up too. So these are some of the summary actions that we said, and I think particularly the one about equity and growing investment, but not just investment in anything. I don't think blind investment just to get to a parity level of investment with physical health care. We've got to invest wisely, and we've got to invest sequentially. And the mental health sector has got to get over itself, I think, in one way, because we can't do everything in one hit. So obviously there are going to be some priorities that are ticked off first, and others that happen a bit further down the track when we have a really good model to invest in. So the sector has got to stop criticising investments in things that are first or second cabs off the rank, and unfortunately we've seen a little bit too much of that in the last couple of years. We've got to actually work together and get the whole package invested in over time. But that's going to require research and development in some areas which really haven't got the answers yet. And that's where the research comes in. Okay, so I think that's the question that my colleague Matthew Hamilton said we should be asking politicians to ask their cabinet colleagues. How close are we to achieving that? But I ask the whole community that. I think it's a question for the whole community. How close are we to achieving that? Because, you have the power, I think. You have the ability. And if your families are not getting that sort of equity and access, then it's up to you to really do something. You can help us to advocate. You can help us to change things, and you can help us to research and learn more and translate. But really, we need you as partners in this. And just finish the last couple of minutes on the research issues again. It's a pretty rough business, scientific research. If you don't perform, the KPIs are pretty ruthless, aren't they, Mike? This is our research facility. Not really, but it is the building. It is the same building, but this is in 1907. It was the reception centre for, I think, Victoria. That all the first episodes came into that building, to Parkville. It's a historic building. Royal Park Hospital was built just down the road, and now Royal Park Hospital is now closed, and we're still there occupying these buildings and some other ones on that site. And contrast that with the Melbourne Brain Centre, and this is showing where Victoria is actually. I think in the neuroscience area, there's been a very great integration of these facilities there. A number of institutes have come together. So in the basic science way, we're actually doing okay, but we haven't integrated that with the practical research that I think that Ian was talking about, and Linda and the Minister as well. How do we integrate those things together? There's some great work going on there, and a lot of our imaging is done in partnership with those people, but Chris Pantelis, I mentioned him in particular. But in Sydney, Ian Hickey has a structure called the Brain and Mind Research Institute, where in the basement you've got zebrafish. I'm not quite sure why they research them, but it's something to do with neurogenesis. And then the next level up, they've got their PET scanners and their MRI scanners, and then the next level up they've got their Headspace service, and then they've got their age psychiatry service and their neurocognitive unit, and so it's all very integrated in a very seamless sort of way. Now, we probably can't do that geographically in Victoria, at least the Melbourne Uni in that way, but what we can do is strengthen both sides of the equation. So the clinical research and the clinical infrastructures are very strongly supported, as well as the neuroscience. And, so in terms of the landscape of mental health research, I think, just to get back to Swinburne again, that's exactly what you're trying to do, integrate those two things. The national landscape, I think the NHMRC had some extra money to put into mental health research as a result of the budget last year, but it's very unclear how well that's going to go. I'll show you some figures in a sec about this. Victorian landscape, the Minister mentioned this very welcome MIRF, Mental Illness Research Fund, which is a fantastic thing to be doing. I've got another suggestion which I'll come back to in a minute, but that is a very welcome, and the focus of it is particularly welcome as well. And I think there are some opportunities. So I showed you the burden of disease before, and I showed you the research funding, how mental health is lagging behind. This is an article that we wrote for the Medical Journal of Australia. I think it was last year, maybe early this year. Helen Christensen, who's the president of the Australian Society for Psychiatric Research, was the lead author on this. And we analysed all the publication data, the investment data, and what we came up with was that there are low levels of mental health funding. It's a national priority area, but it's the lowest of the national priority areas in terms of research investment. Yet the researchers in mental health are outperforming all the other areas in terms of citations. It's quite amazing. If you talk to Warwick Anderson, the CEO of NHMRC, he'll say, we'd love to do more in mental health, but there just aren't the people to do it. But it's complete nonsense. Look at this. I mean, we're way down in terms of investment. We are increasing, but only at the same rate as everything else. So we're still on the bottom rung of the ladder. There's just been a gradual increase in medical research, which is great, but we're still the poor cousin, very much so, even though, as you can see, we're very important in terms of national productivity and all the other parameters I showed you. And these figures are just showing the same thing, where we're low down, improving a little bit, but a long way to go. And this is the data which I was quite amazed by, actually, because I sort of half believed, what Warwick was saying and what people were saying about mental health researchers. But actually, as you can see, the international ranking of researchers in Australia in psychiatry and psychology is 5. You look at neuroscience, it's only 11. Immunology, 8. These are the big investments in research. Clinical medicine, 9. Microbiology, which is one of the big investments too, and so on. I'm not sure where is cancer on there. I couldn't see cancer, but anyway, we're at least doing okay, and probably a bit better than our colleagues. But there's relatively few of us, so Ian's investment here through the foundation, growing a new generation of mental health researchers, is incredibly important. That's what we have to do. The next generation, and it's investing in the future. So I think in terms of the model in Victoria, I know the Minister's looking at this, but you know, our model of investment from the state government perspective in mental health research in Victoria is pretty much designed in the late 1980s, when there was just one mental health research institute, the Mental Health Research Institute of Victoria. Now we have a number of centres like this one, like our centre, like the Alfred one, and probably several others, who are churning out the papers, doing the work, linking the research with the real world. It's a new world. It's quite a different landscape from when the funding model for state government investment in support of mental health research in Victoria was designed. There is investment in a number of positions in many parts of Victoria, in academic places, but again, that hasn't been reviewed for probably at least 15 years. And I know the Minister's looking at reviewing that now. So very timely, needs new investment in the infrastructure as well. It's great to fund projects, which the MRF scheme actually does fund, but what organisations need is critical mass, and they can't survive these days without infrastructure. Infrastructure is not covered by federal government, is not covered by universities, and it's certainly not covered by hospitals anymore. So there's a huge hole, which makes it very, very difficult for people like me to run operations like I run, for Mike to run operations like he runs. So investments like Ian is providing, and other philanthropic investments are one part of the solution, but it's a multifaceted problem, and it needs a multifaceted solution. There's Simon McKeon is conducting a national inquiry into this at the moment, into medical research. It's not just psychiatric research that's affected by this, it's a widespread problem in medical research. The infrastructure, the capital, the facilities, the operating costs, who is going to pay for them so that these young researchers can actually do their work and benefit society? And that's a very big question. So, talent's obviously another big thing. Innovation is a real great strength of Australian mental health research. We're very innovative. European and American researchers are not very innovative, really, I don't think. They're very effective, but they've got a lot of money, and they deliver because of the volume and so on. But a lot of the ideas actually come from Australia, and I think the ideas that have transformed mental health care in the world have nearly all come from Australia in the last 20 years. But we don't follow them through properly, and that's our failing, and that's what we have to do. So, and the final message, I suppose, is that what you're talking about here in terms of research philosophy is something very dear to my heart, the integration of research knowledge and then making it available to people. Gordon Parker, who was the former director of the Black Dog Institute in Sydney, he once said, he was a fiend for publication, and he said, if the research isn't published, it didn't happen. Well, I say if the research was done and it was published and it's not translated into the real world, it didn't happen. So it doesn't matter if it's published in a journal, except to people like me and Mike, but it matters to you if it gets translated into the real world. If you go into your mental health service and not doing the things which are already known to be effective, that's a failure. You know, it's partly a failure of researchers, but it's a failure of the whole process, I suppose. So just that's the goal: equity, access, a fair deal, fair go for all people suffering mental ill health, and the same quality of care. And that will not happen unless this happens, I think. And the fact that you're all here tonight gives me incredible comfort, I suppose, and inspires me very, very much to see you all here, and inspired by Ian and his gesture to help make this happen. Because if we do mobilise the public, and it's helpful to all of us, it's helpful to the Minister, we can get these things done if the public are behind this. But we have to break through the inertia, we have to break through the apathy in a way, and the feelings of helplessness that we sometimes feel about these things. We feel like it's too hard, but it's not too hard, because we have made very significant gains and we've got a lot more to do, and a lot of people are depending on us doing that. So thanks very much for listening. Thank you, Mike. Thank you.
Thank you so much. We were going to have time for some questions, but we've just run fairly significantly over time, so we might just hold them for the end. We'll have the opportunity to meet with Professor McGorry and some other members of Swinburne staff over in the front room, so please join us there. If there's just a couple of messages I can leave for you as you leave tonight. We've talked a lot about Swinburne being a place where you can realise a philanthropic vision, and the Barbara Dicker Brain Sciences Foundation is really a shining example of that. But philanthropy is something that all of us can participate in. So you'll each have received on your seat a Barbara Dicker Brain Sciences Foundation brochure. We would really appreciate it if you consider Barbara Dicker's legacy and perhaps making a small consideration to us. If any of you are interested in talking to us more about the work of the Foundation and perhaps getting involved, please do contact us. Our contact details are on the back of the form. We will be having some tours at the end of this evening. Now, not all of you will get an opportunity to participate in those, so don't hesitate to give us a call. We'd be happy, even if it's just one of you on your own, give us a call. We'd be delighted to take you through, because the equipment that we have here, literally underneath your feet, humming away now, is absolutely fabulous. There is really only one institution in Australia that has this concentration of equipment here. It's really worth seeing. So once again, thank you so much for joining us tonight. We look forward to seeing you again. Have a safe trip home and take care. Good night.
This has been a Swinburne production.